Good afternoon, and welcome to today's Side by Side with the Division of Mental Health, Developmental Disabilities, and Substance Use Services, Improving Our System Together monthly webinar. Before we get started, here are a few reminders about the webinar technology. Please make sure that you're using a computer or smartphone connected to the internet and that the audio function is on and the volume is turned up. Please be sure your microphone is muted for the duration of the call unless you are speaking or asking questions. Questions can be submitted anytime during the presentation using the Q&A feature located on your control panel. We will answer as many questions as time allows after the presentation. American Sign Language interpreters and closed captioning options are available for today's event. The American Sign Language interpreters for today are Danette Steelman Bridges and Susan King Lanier. For closed captioning options, select the closed caption feature located on your dashboard. To adjust the video layout and screen view, select the view feature located in the top right-hand corner of your screen and choose the view that works best for you. Today's agenda topics include introductions and mental health, substance use, intellectual and developmental disabilities, and traumatic brain injury system announcements and updates. Our focus today is increasing access with integrated care. We will discuss collaborative care, NCPAL, and certified community behavioral health clinics. At this time, I'd like to turn it over to Kelly Crosby, Director of the Division of Mental Health, Developmental Disabilities, and Substance Use Services.
Thank you so much, Dina. Hi, everyone. It's Kelly Crosby. For those of you that don't know me, as Dina said, I'm the director of our Division of Mental Health, Developmental Disabilities, and Substance Use Services, also traumatic brain injury and problem gambling. So really happy that we could join you all today. There's a little bit about me on the slide, but you're going to see me try to hurry today, which is not something I'm good at all. But we have some amazing and wonderful guest speakers, both within our division and also some of our community partners. So I want to make sure we have plenty of time to get to the meat of today's conversation. So with that, I'm actually going to go through some important announcements and updates about our system. I'll probably pause the longest in talking about federal updates because I know folks are really concerned about federal updates. And then I really want to spend time digging into today's topic, which is integrated care. And for us, integrated care is very much about creating access to physical health care, absolutely, but even more access to mental health and substance use care in integrated settings. Okay, so let's do some system updates first. We've got a lot of awareness things happening this summer. So first, let's just talk about July and some of our awareness celebrations. It is Bebe Moore Campbell Minority Mental Health Awareness Month, and we just use this as a time to remind folks that people who are from Black, Indigenous, and people of color, those communities often have a great need for mental health and substance use care, but do not have access. And we know there are a lot of barriers, stigma, just general access to competent and culturally humble providers, and lack of insurance. There's so many factors that go into people not having access to care. And so one of our priorities here at the state, and that's kind of the theme of today, is making sure that all of our communities and all people have access to high quality mental health care. Next slide, please. This month is also the anniversary of the ADA, which is something to celebrate. And so you'll see on this slide some information about the ADA, but also in particular, I want you to see the Google Sheet because we are having a 35th anniversary celebration here with the department. We're having it downtown. We welcome you all to come. We're very excited about lifting up some wonderful success stories from people in our community. And we just want to celebrate the ADA because, again, we should have the most inclusive society possible, and everyone should have the right to work and live in the community of their choosing in any way that they want to. So we really lift up the values of the ADA here and hope you can join us for the celebration. Next slide. July is also Disability Pride Month. And so again, we want to remind everyone that 1 in 5 people have a disability. So people with disabilities are us. It is our community and it is our world. And we want to make sure that we're lifting up and honoring people with disabilities in our community, disabilities of all kinds, and really recognizing the contributions and the really significant and amazing ways on a daily basis that people with disabilities make our lives richer and fuller. They are our friends, our loved ones, our neighbors, our coworkers. And so we want to lift up Disability Pride Month this month. Next slide. July 22nd, which is coming up really soon, is also Fragile X Awareness Day. For those of you that don't know, we have a really thriving Fragile X Association right here in North Carolina. You'll see on this slide some information about the National Fragile X organization. But remember, Fragile X is the most common inherited cause of intellectual disability, period. And so a lot of you may know individuals or have loved ones or family members with Fragile X. It's a really important time to remember folks, to support their activities, to become involved in the community. And so we want to celebrate Fragile X Awareness Day. Next slide. Another big anniversary is coming up, July 16th. So just in 2 days, it is the 3rd anniversary of 988. You'll see messages coming out from us. I want to remind folks about our dashboard. We've reached over 135,000 people already through the last year even. And remember, this is the 3rd anniversary. So just hundreds of thousands of people have been supported. We continue to maintain a very high response rate, a very high satisfaction score across 988. And why does that matter? It means that people who are using the line are actually finding it helpful. And when you see some of our announcements coming up this week and over the following next week, where we're celebrating the successes of 988, we will actually share for you real life experiences of people who have called 988. Remember, there's no wrong reason to call 988. It is the crisis lifeline. So absolutely, we want people to call who are in crisis. Crisis means very individual things for everyone. So it could be an interpersonal issue, depression, anxiety. It could be you're feeling guilty or not feeling like you want to live here anymore. So please call for whatever reason and share this message to everyone you know. 988 saves lives. Next slide. Want to do a few quick program highlights. And again, I know I'm going faster than I normally would, but I want to get to the meat of today's topic. So the first program highlight is on the next slide. So I hope by now all of you have seen some of our announcements around some changes to federal funding of 988. So 988 will continue to be funded at the federal level, but there was a very specific program called the Trevor Project that was part of 988. So if any of you have ever called 988 or heard the prompt when you call 988, the message will say you've reached 988 and it allows you to press certain buttons. So if you're a veteran, it'll say press 1 if you want to speak to our veteran specific line. Hit 3 if you want to speak to our Trevor line. And the Trevor line was a special hotline funded at the federal level for youth who identify as LGBTQT. So the federal government, as of July 17th, is no longer funding the Trevor Project. But we have released a statement, and I want to assure folks here that 988 is still going strong, still fully funded. And just because you can't press 3 anymore, it doesn't mean you shouldn't call 988. So we encourage you to tell your friends, get the message out. We're very committed to ensure that 988, whether you call, whether you chat, whether you text, is there to meet the needs of all North Carolinians, however you identify. So we've got a great 988. I don't know if you know that, but we've got one of the best in the nation. That's our Real Crisis Center. That's their actual name. They have incredible training, and they are ready. They've been preparing, and they are ready to meet the needs of youth who call or chat or text and identify as LGBTQT. Next slide, please. Let's see. I think it was about a little over a week ago, maybe 10 days ago, the big beautiful bill passed. And no, it wasn't that long ago. Oh yeah, it was that long ago. I was gonna say it was right before 4th of July, so I got my days right. We call it HR 1, which is the technical name of the bill, House Resolution 1. It did pass, and it has significant changes to the federal Medicaid program, which trickles down to states' Medicaid programs, of course. Secretary Sangvi did release, that is our secretary here in North Carolina, he did release a statement saying, we are concerned about the changes that we see. It will have very real impacts here in North Carolina, but we need some time to digest and understand both the timing and the changes here in North Carolina. I sent out a statement last week just to remind folks that as soon as we get more information to understand the impacts here in North Carolina, we will certainly share that. There is still time, we think, to impact the federal rolling out of this bill, the state response to this bill, and the way we roll this out at the state level. But by and large, this will impact the way that we can finance Medicaid in our state, meaning the way we might tax hospitals to fund the state part of Medicaid will change. There will be limits on how much we can do that, which will in turn cost more at the state level. And there also will be changes to the way people can become eligible for Medicaid. That will include things like more frequent redetermination requirements, so people having to get their Medicaid looked at every 6 months, for example, their eligibility. It will mean certain groups will have to work. People who got Medicaid under expansion will have to work a certain amount of hours, or people with serious mental illness, a disability, or a substance use disorder may be exempted from those work requirements, but will have to prove they are in active treatment and have the right diagnosis. That's big. Those are big changes, everybody. So what I want to tell you is there's still a lot of work to do to understand how those changes will affect us. There's a lot to do to think about how we actually implement those changes as a community. We will want your input. And then finally, what the timing of those changes are. It's not going to happen tomorrow. It's going to take some time. And as we get information and as there are opportunities for input, we will share information and solicit your input. But like I mentioned last week, if you get Hot Topics, you hopefully saw my message, maybe you read it, but we're going to be okay. I know some people are very anxious. You're worried about what this means for your services, what it means for your family, what it means for you as a business, and what you can bill, and how that's going to change. And I know for some people it's scary, but I want folks to remember that just by default, we are a community who's incredibly resilient, right? I can rarely think of a time where we have been funded adequately or policies really worked really well for people with serious mental illness, substance use disorder, intellectual developmental disabilities, or traumatic brain injury. We understand hardship at a very personal level, at a policy level, at a community level. And we're going to stick together and we're going to figure this out, and we are going to be okay. If you don't feel okay, reach out to your friend, reach out to your colleague, even call 988, okay? But we're going to be okay. All right, next slide. We have coming up with NAMI, a State of North Carolina Mental Health Town Hall at the end of the month. I encourage you all to attend, register, and come to that. I'll be speaking. We'll be talking about mental health. We are full bore in mental health, y'all. Despite what happens to Medicaid, despite any other federal or state changes, we are full bore. We've got a system. Our system needs improving. We're working on it hard every single day. Today, we are talking about some of the things that we're working on to make a better system. And so please come to this meeting if you're interested. And we'll be talking about the state of mental health, our successes, and what we're still going to keep on moving forward. We are very committed. That commitment hasn't stopped, neither has our hard work. Next slide. A couple other announcements that I'm looking at my time. I think I'm doing okay on time. There's a lot. So what I'm asking of all of you is, obviously, if it's a topic that's interesting to you, you're going to perk up and really listen to it. But everyone, these slides are posted, and our team will put in the chat if they haven't already where you can get these slides. So if I go through something too fast, please go to the slides. Remember, we've been working with you as a community on peer support policies and the peer support certification process. A lot of new things are going live tomorrow. So policies have changed for certification. We're launching the online course training. Then in September, we're going to launch the in-person part of training. There are new ways you can sign up to be a trainer. You can get a scholarship to become a certified peer specialist. I have an ask of you. If you're listening to me right now and you know about the scholarships for peer certification, you know about these changes, you know about our website, would you please share it? Share it in your community. I keep going to communities and talking to peer support specialists, and they don't even know that changes are being made. They don't even know they can get a scholarship. And so please spread the word. We're going to try to keep spreading the word ourselves. Remember, just go to our new peer support specialist webpage. You're going to read a lot about the changes, but remember, these changes were done in partnership with you because we believe peer support specialists are amazing and superstars, and they're a huge part of our recovery system here in North Carolina. We want to make sure people feel well informed and well supported to go be a peer support specialist in their communities. And so thank you for your partnership in making our certification process even stronger. So go to that website to see about changes and scholarships. Next slide. Our suicide prevention action plan is still posted for public comment. I think maybe for 2 more weeks. Read it, care about it. Every single one of us is impacted by suicide. It's really sobering, you all. So look at our plan. We've developed it in partnership with the community. So that's providers, it's counties, it's people who've been impacted by suicide. We've got a lot of activities in there for what we want to do about education of our communities, prevention activities, follow-up care, treatment, a stronger 988 and crisis system. But please give us your feedback. Tell us what's missing, okay? So read the plan and give us your feedback. Next slide. We have finalized our Black Youth Suicide Prevention Action Plan, and we've actually been trying to promote this and do some news stories on it because it's a real issue, you all, if you're not aware. So we've seen a sharp increase of completed suicides in Black youth, specifically male Black youth. And we worked with the community. We got technical assistance at the federal level so we could put together a plan that makes sense in communities. It's not us. We have community, we have a youth advisory group, we have community advisory groups, and this is a real partnership with the community. So we got your feedback. Thank you very much for sharing your feedback on the plan. Things are already underway, so read the plan if you're interested. Of course, you're interested and you want to be a part of it, let us know. We're happy to have you be a part of it. But this is an area where we can turn the tide and save lives. Next slide. Totally switching gears. Inclusion Connects. You all know what Inclusion Connects is, right? A hope. Remember, Inclusion Connects is our initiative to support people with intellectual developmental disabilities. And I keep saying to everybody, guess what? We didn't get slots this year. Y'all know that, and I know you're terrifically disappointed. I am too. But Inclusion Connects is about making sure more people get more services. We have a strong direct support professional workforce. And we have a robust array of housing opportunities for people with intellectual and developmental disabilities. It's bold, it's ambitious, it's 3 really big things. It's not everything. There's more things to be done, but we're still working really, really hard at it. And so one of the things we like to do is lift up and learn from success stories. So on our Inclusion Connects website are 2 links. One is if you're a consumer and you want to share your success story, and another one is if you are a provider or a support professional who's helped someone reach their community goals or is in the process of reaching their community goals right now, because that's ongoing, right? All of us are working on our community goals. So please look at those surveys, and we would be really, really appreciative if you would share your stories with us so we can share them with the community. The next slide is some more Inclusion Connects, if we can go to the next slide. So hopefully all of you know that we do have an advisory committee. We also have lunch and learns all the time for Inclusion Connects. And we welcome you to join our meetings so you can learn about what is happening through Inclusion Connects. We share lots of data on the dashboard, new people who are getting services on the innovations waiting list, new people who have outreach, people that are transitioning to the community. So we share lots of things and we get your feedback about how we can do things better. So feel free to join us. On the next slide is an update on Inclusion Works, I believe, if memory serves. So remember, Inclusion Works is part of Inclusion Connects. Yep. Inclusion Works is making sure that we're supporting people with intellectual and developmental disabilities to be competitively employed if that's what they so choose. It means working in inclusive workplaces, working where you want, getting paid a fair wage, getting opportunities for advancement, just like everyone else, right? And so we are working with providers. We've given out provider grants for some providers to modernize and innovate the way that they are doing employment opportunities for people with intellectual developmental disabilities. So congrats to our 4 winners of those grants. We're very, very excited to work with you. Next slide. We also have a person-centered learning collaborative coming up. There's a bit of an orientation. You'll see here for the information about how you can sign up and join the orientation. Person-centered, it's a term that we just use all the time. And when people hear person-centered, they think person-centered plan. I just want you to think about it in the most broadest sense. How do you, no matter what your role is in this system, if you're a provider, if you're a direct support professional, if you're a QP, if you're a leader in an organization, think about how you can make what you do more person-centered. Our services are not, we do the same block of 6 activities with everyone. Everyone is unique and beautiful. They have their own needs, they have their own goals. And we are trying in North Carolina to ensure that we have a system that honors everyone's goals and helps them in their own unique way be included in the community or be in recovery in their own way. So person-centeredness should be just the way we do business. So come on down to the Person-Centered Learning Collaborative. Next slide. If you're not connected, sign up for Hot Topics. I don't think you'll be sorry. I think our Hot Topics are great. Dina crafts these every week. We send them out twice a week. We try our very best to keep you informed, and there's always something going on in our system, like always, always, always. So please sign up in Hot Topics. You may even see yourself or your organization featured in Hot Topics. We love to feature you all and in your conferences and celebrate your wins. So please sign up for Hot Topics, and there is how you can do it. I think that's our last slide before we get into today's topic. Okay, I raced through all of that, and I'm sorry, all of that was actually really important, but we really needed to make time for our special guest. So today we're going to talk about integrated care. Y'all know what integrated care is, right? We've been talking about integrated care for years, years, and years, and years. But it's the idea that people are a person. We're a whole. We're a whole person. We just all are. Mind and body, right? Mind and body. And whole person care too now helps us really think about not just like physical and mental, which includes substance use, it includes intellectual, includes developmental, but it also includes factors in our lives that influence how we think and feel. Like if we have enough food to eat, if we have a safe place to live, if we have a job that fulfills us, right? But we're going to talk very specifically, when we talk about integrated care today, we're going to talk very specifically about making sure that when you go to work with a practitioner, whoever that is, whether it's a mental health provider, a substance use provider, a primary care provider, they're paying attention to you as a whole person. And why does this matter? Well, we have some statistics on here that talk about why it matters, but we know that people in particular, we've talked about this for so long, but people with serious mental illness, right? People with schizophrenia, people with bipolar disorder, people with recurrent chronic depression, people with obsessive compulsive disorder, right? Can be serious life-altering things. Those folks are not getting access to good, high-quality primary care, and therefore are really suffering from a lot of preventable things, diabetes, cardiovascular disease, and then sometimes people with serious mental illness take medications to help with their mental health symptoms that actually do detriment to their physical health. By the same token, individuals with substance use disorder, oftentimes those substances actually have real physical consequences to the body and brain, organic physical consequences. But also, it can be hard to find a practitioner who can see you as a whole person, right? Whether you have a serious mental illness, whether you have a substance use disorder, it can be hard to find a primary care doc who's looking at you as a whole human and understanding the interplay between your mental health issues and your substance use issues and your physical health issues. Another complication as well is if you have intellectual and developmental disabilities. There's a lot that we've been trying to do for a while. We won't really talk much about it today. Gary will talk a little bit about it, but making sure that our primary care doctors understand how associated physical issues, if you have certain intellectual or developmental disabilities, or how those things may present and how your physical healthcare may look different. So the whole point is that we want to make sure that people, our community, people with mental health, substance use issues, intellectual and developmental disabilities, traumatic brain injury, are getting good whole person care. We deserve it, y'all. We deserve it. And another interesting thing about integrated care and the models we're talking about today recognizes the fact that, you know, we're only human, right? And we have only so much time and resources and energy in a day. And sometimes we prioritize our own one need over another need. So we may prioritize for ourselves, for our kids, for our brother, for our parent. We may prioritize their substance use treatment or their mental health treatment. And that's what we have time and energy for because it seems the most predominant and pressing. And sometimes that means we don't think about as much or advocate as much for physical health care, or it becomes secondary. It happens all of the time. So we want to make sure to the best of our ability that we're building systems where we can go to one place, and that one place can try to help us with all of our needs. So there's so many reasons that we want to care about integrated care. And hey, tailored plans. That's why we did tailored plans, right? We've asked our LMEs to look at us as whole people, care about our physical health, our mental health, if we're using substances or not, if we've got intellectual developmental disabilities, if we have brain injury, look at us as a whole person. All right, so that's integrated care. Next slide. We are going to talk about three models: collaborative care, which Dr. Carrie Brown is going to talk about, and CPAO, which Dr. Gary Maslow is going to talk about, and then our certified community behavioral health clinics. So the first two are very much about how do we make sure that your primary care doc understands mental health, can help you with mental health, can help understand substance use, can help you even prescribe MOUD, can help you if you have intellectual and developmental disabilities right there in your primary care space. And then Alex and Catherine are going to talk about the other end of the spectrum. We've got a lot of folks in our system, and this is cool. They're going to show up at a mental health provider. They're going to go to Southlake, which Catherine's going to talk about. And we're going to wrap them up with our mental health and substance use services and peer services. But how do we make sure that their physical health needs are being met too, right? So we're trying to help our all, no matter where you go, that they see you as a whole person and they can get evidence-based services there. So without further ado, I'm turning this over to Dr. Carrie Brown to talk about collaborative care.
Good afternoon, everyone. I hope everyone can hear me. Maybe someone can give me a thumbs up so I know that we're.
It's a little quiet, Carrie, but it's okay.
Okay, I'll talk loudly. That's usually not hard for me. Good afternoon, everyone. I'm really excited to be here this afternoon to talk about collaborative care, which has been a passion of mine ever since I came to the department. You want to move on to the next slide, please? So why has the department invested so heavily in the collaborative care model? And there's a few reasons for this. One is access. We really want individuals across North Carolina to have access to evidence-based care. And the collaborative care model has an extensive evidence base for treating mild to moderate mental health and substance use disorder conditions. And it's known to produce superior patient outcomes in a very systematic way. And the other important thing is that we know that the clinicians, the primary care physicians that are part of these models really have high satisfaction along with the patients. And so we really, it's been a primary goal of the department to increase the access for North Carolinians to the collaborative care model across North Carolina. It's really a primary sort of fundamental pillar of offering a population integrated care. Next slide, please. And hopefully we can just hit play. This is I promise it's short, but it's a short, really nice description of collaborative care. So I'm gonna just ask that we play this short video, please.
You don't always seem to have good luck with videos, it would seem. Oh, now it's moving, but we can't hear it, I don't think.
We may want to try reversing the slide and then coming back to it.
Let's give her one more try.
And probably the microphone for whoever is showing the slides needs to be unmuted.
All right, last try. No go. All right. Is there a team, Carrie, is this something we can put in the chat for people to watch later or not?
Yes, absolutely.
Okay.
We can definitely do that. And I just sort of give a verbal summary, but it is a really informative, quick video. So I encourage people to watch it at their leisure. Okay, next slide. So let me go into a little bit more detail here then about how this works since we didn't have the video. So what is the collaborative care model? The beauty of the collaborative care model is it delivers behavioral health care in a primary care setting, which really improves access to care. It does this by expanding the primary care team with a behavioral health care manager that's embedded in the practice and a consulting psychiatrist. And you can see the sort of feedback loop here. So the patient's in the center, they go to their primary care provider, and with the assistance of a behavioral health care manager and some systematic case review tools and some evidence-based assessment tools, work with a psychiatric consult to provide effective behavioral health care for mild to moderate behavioral health conditions. Next slide. So we began on this journey to really implement collaborative care in North Carolina back in 2018. And that started with North Carolina Medicaid adopting the collaborative care codes for reimbursement so that primary care practices could adopt the model and bill for it to North Carolina Medicaid. However, one of the things that we discovered was that the utilization wasn't what we expected. There wasn't as much adoption of the model as we were hoping. And then, COVID really highlighted the need for high quality behavioral health care to occur in the primary care settings because so many people, that's where they had to access, and also reducing the burden on primary care practices that often try to be all things to everyone. So we formed a statewide consortium in 2022 that did a number of things. So first, we really wanted to promote coverage across all payers, because you would imagine if you are running a primary care practice, it's going to be most sustainable. A new model is going to be most sustainable if all of your patients' insurances accept the billing codes. And so we aligned that, and we aligned the billing codes and the coverage across those commercial payers, as well as Medicaid and Medicare. And then to incentivize and also to push our commercial payers to also incentivize the model, we increased the reimbursement by NC Medicaid for collaborative care to 120% of Medicare. So again, just trying to really incentivize adoption of the model. We wanted to make sure that it was affordable for patients. So we removed North Carolina's copays, our Medicaid copays for patients. We created a technical assistance and training resource for providers through NCAHEC. We identified psychiatrists because obviously this model depends on having psychiatrists available to primary care practices to contract with. And so we identified psychiatrists that were trained and willing to be consulting psychiatrists. And psychiatrists love to participate in this work because it allows them to reach so many more individuals. We developed a model contract so that it would be easy for primary care practices and psychiatrists to contract with each other. And then we developed and funded a patient registry, which is a requirement of the model for providers to use for up to 3 years. Next slide, please. And I'm really happy to report that all of these efforts have led to a growing adoption of the collaborative care model across North Carolina. You can see that there's a steady increase in providers billing collaborative care codes by month. This is looking exclusively at Medicaid providers, this particular graph. Next slide. One of the other barriers to adopting the model we realized is that primary care practices often need some capacity building or startup funds to adopt the model because, as you might imagine, you have to hire a behavioral health care manager and you have to contract with a consulting psychiatrist before you're able to bill for reimbursement. And so we wanted to make sure that in those startup costs, we wanted to take away every barrier to a primary care practice adopting this model. So we advocated with the North Carolina General Assembly and were given $5 million in one-time funding that is available now to invest in primary care providers adopting this model to cover their startup costs so that it is easy for them to adopt the model. We have, the good news is that applications are still being accepted. So I encourage you, if you are a primary care practice, to take a look at this. If you are a patient, to ask your doctor if their practice has knows about this and has applied, because this really will help them with their own job satisfaction and create access in the community to behavioral health care. Next slide. This is just a QR code that gives you a direct link to the application for funding, and that will be available when we release the slide. Next slide, please. And just a little bit more detail about the capacity building funding, just so people are aware of what's actually available. The first thing to know is that primary care practice entities can apply for one or more sites. So you may have multiple primary care clinic sites and you can apply for each site. And so each site is potentially eligible for up to $50,000 to newly adopt the collaborative care model. And for those that have already adopted the collaborative care model but want to expand, they're eligible for $30,000. And then for those practices that want to adopt the collaborative care model but are going to do that by outsourcing the behavioral health care manager and psychiatrist to an external vendor, we have $20,000 available for startup costs. Next slide. Great. I would now like to hand it over to my colleague, Dr. Gary Maslow, to talk about our North Carolina Psychiatric Access Line, which is another way to supplement our primary care providers with support so that they can be in the best position to provide whole person and integrated care.
Thanks, Carrie. Gary, can I hop in super quick? Carrie just said something that inspired me for a second, and I think it will flow nicely into your presentation as well. So when you put this into like real life experience, right? Your general population, right? Just any of us, right? Or our neighbors or our friends or our family, even my family, right? when you think about getting mental health treatment, it unnecessarily, but it makes people nervous. There's just a lot of stigma and a lot of fear, and people don't know where to go. But people do tend to go to their primary care doc. And if you can go to your primary care doc and talk to you about your depression, your anxiety, your teen's depression or anxiety, and your doctor feels comfortable helping you, they can reach out to a psychiatrist for help if they want to prescribe you medication. They have a social worker in their office that can help you, like in the collaborative care model. That's a really good thing. It's helping people in a space where they're really comfortable, and it's helping us get a lot more access, because something that Dr. Brown mentioned, I'm sure Dr. Maslow will mention it, is we really struggle to have enough therapists, enough psychiatrists, and people still are confused and don't know where to go, and they're unnecessarily ashamed or embarrassed to go for mental health treatment. We're working on that, right? Because no one should ever be ashamed or embarrassed. But if you can just get some help in your primary care's office before it gets really bad, that's wonderful. And if you can feel confident and your doctor can feel confident that they can help you, this is a really, really, really good thing. So thank you, Carrie, and over to you, Dr. Maslow.
Well, thank you, and thank you all. Thank you, Kelly, for having me, and it's nice to be here with everyone today. And you can go on to the next slide. I like everyone else will try to be brief. So I am a primary care pediatrician and also a child psychiatrist at Duke. I've been at Duke for 15 years and been doing primary care for much of that whole time. And one of the things that I think, as Carrie is talking about, is the difference that I've seen personally in what I can do for my patients because of having collaborative care available, and how that can help people who previously would not have had access to, high quality depression care. Even though I have that, I personally can do some of it, but having that care manager makes such a difference. I've personally, for my patients, seen the value of 988 and have had multiple patients come in and say, I'm really glad 988 was there when I was in a crisis, and have used that service. And then, all the other kind of changes that have happened with Medicaid and tailored plans and some of the care management. There's a real, for me, a before and after when some of these programs that support primary care to do this have come into place. And so grateful to be a part of this state and see, the efforts being made on behalf of integration. As you all know, there is a real mental health professional shortage. There are many different maps, but this one really highlights that there are only 3 counties in North Carolina that have a adequate number of mental health providers, and most have inadequate amounts. And primary care doctors, particularly those in rural areas, are the most available to diagnose and help people who have a range of different conditions. Next slide. To address the fact that primary care physicians and nurse practitioners and PAs and other practitioners are the workforce caring for individuals with mental health conditions or intellectual and developmental disabilities or substance use disorders, that we've had for the last since 2017, so 8 years of programs in North Carolina that aim to build the mental health and IDD health knowledge base for those in a range of settings. And then also for women who are in the pregnant and postpartum period. And NCPAL is North Carolina Psychiatry Access Line and works with the perinatal program named NC Matters. Next slide. So on the next slide, I think there's kind of a picture. NCPAL is supported by the state, supported by Medicaid, and as well as federal funding from HRSA and SAMHSA. And there's a lot of information on here, but the core thing I think is that our goal is to support primary care providers and help them with education, because many of them did not have education about mental health or substance use or intellectual development disabilities. So help them with trainings, as well as be available for real-time consultation. So it's very much an adult learning model. If you are a primary care doctor and you meet a patient who has anxiety and you don't know what therapies are available in the community, you can call NCPAL and we'll have a referral coordinator help you find who is available to help that child with anxiety and their family. And so it's really, and then the next time you have that situation, you can just use that information because you've learned it. And so it's really kind of a model of being available to help someone, and then they can then take it on and learn from that. In addition to this kind of direct consultation and education, we also do practice support. We are working with practices to implement collaborative care, working with practices that are to help them be prepared to work with individuals with intellectual and developmental disabilities, and having supports of when a child comes in and needs a blood draw and they have autism, what are ways to help them and their family be able to do that? Working with the early childhood workforce, as well as the DSS, social services in schools. So NCPAL, again, is a consultation program that is really meant to be infrastructure for the state to allow for this integration, and to have experts in child psychiatry, psychology, social workers available to support folks across the state. Next slide. The way it works is someone calls the number. I think it's on here somewhere, but the provider calls the number, they can get real-time consultation, and then they can also have access to in-depth education. Next slide. In addition to the real-time consultation I was describing, we do these REACH mini fellowships, which are essentially a patient-centered mental health in primary care training. It's 28 hours, so it's a weekend-long training, and it's a national one. They get, the providers get CME. We've had over 500 pediatricians and family doctors and NPs and PAs go through the training. And one of the participants, the quote here is, "The course was so practical for my practice of pediatric mental health. It was beautifully organized, and the teaching was practical, focused, and was the best CME I've ever attended." And I think I've taught these courses and participated in them, and it is really incredible to bring together 25 providers from across the state who have very different experiences with mental health and working with children with a range of conditions, and for them to get on the same page and really feel more comfortable going back to their communities and doing that. And so the fact that, with the state support and DHHS's support, we're able to train over 100 something providers a year. Our goal is to get to 1,000 in the next 3 years. We'll see if we can do that. But really get to that workforce so that all those counties that don't have providers right with experience and are part of that shortage, they have primary care providers who are able to step in and feel supported. Next slide. So again, here's the phone number if anyone is a provider and would like to call. But basically, it's a live 5 days a week, Monday through Friday, line. We currently have for pediatrics, especially including children with young children, intellectual development disabilities, as well as a perinatal line. One of our hopes is over this year is to add number 3 for adult, and so be able to support family doctors or others who are working with adults with a range of mental health conditions, and then hopefully be able to have press 4 for substance use disorders to support in more depth providers who want to do substance use treatment. And so really being able to support broadly the behavioral health needs of folks in North Carolina through supporting their primary care doctors. Next slide. I think this will be my last main slide. This just gives you a sense of the engagement. The darkest color is around 500 calls. And so you can really see that there are areas that we have not gotten calls, but over, I think, 80 counties have been engaged with North Carolina, and the dots represent counties where we've had a caller, someone do the REACH training. Over 1,000 providers have used the phone line, and again, over 500 have been trained. And our goal is to keep growing that number and keep reaching communities that don't have as much access. I think the next slide is my last slide. Thank you for the opportunity to be a part of this presentation today, and for the support. I'll hand it over to, I think, Alex next.
Thank you, Dr. Maslow. So today I'll be talking about certified community behavioral health clinics. So I'm Alex. I'm a mental health consultant focused on integrated care. And for the last year, a lot of my time has been focused on CCBHCs. Next slide, please. So what is a CCBHC? CCBHCs are certified community behavioral health clinics. These clinics provide comprehensive coordinated behavioral health care with an enhanced focus on quality and evidence-based care. They serve anyone seeking mental health or substance use treatment, regardless of their ability to pay or place of residence. CCBHCs focus on whole person care. They either provide directly or contract with a collaborating organization to provide 9 core service categories. These categories include peer support, counseling, and family support, crisis mental health services, screening, assessment, and diagnosis, patient-centered treatment planning, outpatient substance use and mental health services, outpatient clinic primary care screening and monitoring, targeted case management, psychiatric rehabilitation services, and intensive mental health care for veterans. Right now, North Carolina doesn't have a formal CCBHC certification process, but we're working on developing one. Today, we define our CCBHCs as providers who've qualified and received specific CCBHC funding at the federal or state level. Next slide, please. So on this slide, I want to note that over the past several years, there's been over 12 organizations that have received CCBHC funding at either the state or federal level at some point. But on this slide, we'll focus on the 5 CCBHCs that currently work directly with the Division of Mental Health, Developmental Disabilities, and Substance Use Services as CCBHC grant recipients. These organizations include Anuvia Prevention and Recovery Services in Charlotte, B&D Integrated Health Services in Durham, Coastal Horizon Center in Wilmington, Mountain Area Health Education Center in Raleigh, or in Asheville, and Southlight Healthcare in Raleigh. In 2024, these 5 CCBHCs served over 17,000 individuals. And the heat map to the right shows where the majority of those patients resided. And I think one of the cool things about this map is that it shows that these 5 CCBHCs made an impact in almost 90% of the counties in North Carolina. Next slide, please. Earlier, I brought up how North Carolina doesn't have a formal certification process and that our CCBHCs are funded by grants. So to help us achieve our goal of increasing access to integrated care across the state, the Division of Mental Health, Developmental Disabilities, and Substance Use Services obtained a planning grant from the Substance Abuse and Mental Health Services Administration to develop a formal North Carolina CCBHC certification process and criteria. And essentially, this grant is helping us to define things like what does it mean to provide crisis care as a North Carolina CCBHC, or what exact outpatient services are essential for our communities, or how do we step things up beyond just primary care screening, but how do we position our CCBHCs for an even greater integration with primary care? And another aspect of this grant is developing a prospective payment system. And this payment methodology looks at the cost of providing services and creates a more sustainable funding mechanism for our CCBHCs to thrive. And now I'd like to hand it off to Catherine, who's one of our CCBHCs.
Yeah. Hi, good afternoon, everybody. My name is Catherine Schley, and I'm the Chief Strategy Officer at Southlight Healthcare. And you can go to the next slide. I'm going to try to go really quickly because I know we're very short on time, and just talk a little bit about what it has meant to Southlight to be a CCBHC. So next slide. When we first received the grant, we had to come up with some goals about what we wanted to have as outcomes from this grant. So these are the 5 areas that we decided to really focus on: expanding access to behavioral health care, expanding access to primary care services, improving staff retention and experience, access to crisis services, and decreasing barriers to care by addressing social determinants of health. So as you can see, this really does kind of play to that whole person care that we've been talking about today. And on the next slide, we'll talk very quickly about some of the outcomes that we've achieved through that. So over the last 3 years, we're now serving upwards of 5,500 people per year. Over 1,400 people are served in our opioid treatment program last year. About 63% of our folks now have Medicaid, and 80% are dually diagnosed with mental health and substance use diagnoses. When we started 3 years ago, we had about 125 employees, and today we have 230. So we've really been able to increase our staff, and a lot of our folks have lived experiences at all levels of our organizations, from our executive level all the way down to people working on the front lines, and all across the organization. We've worked to create really competitive salary bands and do things like offer free continuing education opportunities and reimbursements for clinical licensures, just to really improve that experience for our staff. We've also done some innovative things like creating a peer-led drop-in center to address those social determinants of health, have evening clinic hours in our opioid treatment program, and have developed an integrated health clinic where we have a model of doing a little bit more than just that assessment and screening, but really kind of triaging folks and doing a lot of work with care coordination to get them connected to primary care homes, while also tending to some of those needs in-house while we make that connection. And we now have 6 locations. Our Wake County location is our CCBHC hub, our home, and we kind of have a spokes model where we have offices in Durham, Cumberland, and Harnett counties as well. Next slide. And just to kind of wrap all of that up, becoming a CCBHC has done a lot for us as just, evidence there, but we've also become the first CARF accredited CCBHC. We're working to obtain accreditation through NCQA, and we're just increasing access and serving more people, decreasing the cost of the communities through this program and becoming a really strong solution partner to folks in the community. And so we're just really excited about this opportunity and what the future holds for CCBHCs. And just as an organization, we've really integrated this CCBHC model of care, this philosophy, into how we do all of our programming, how we complete our strategic plan, and how we think about growth in this in our organization and in our community. So next slide. So that's it really quickly. So I hope that's a helpful kind of insight into what it looks like to be a CCBHC. And I will hand it back over to Kelly.
Catherine, thank you for that speed round there. I really appreciate it. And you may have seen, several months ago, a hot topic and a LinkedIn post on our visit to Southlight. It was truly inspiring. One of the things that just overall that I want to celebrate about collaborative care and NC-PAL is, again, more people are getting whole person care right there in their primary care office. Primary care offices are more comfortable talking with people about depression and anxiety, which is good. Let's find it early and now. We're reaching more pregnant women and women who've just delivered with mental health care, with supports to their doctors, their primary care docs, their OBs. So we are really, in many ways, extending our workforce greatly and making sure people get whole person care. On the collaborative care side, I hope that you heard that theme of people can get a good continuum of care, right? And also get their primary care needs addressed. So Southlight is a wonderful example of folks who can come for a whole complement of mental health and substance use services, have a drop-in center. They have a really cool drop-in center. They've got peers, they've got walk-in appointments. They do wonderful after-hours crisis, and they coordinate with primary care. And our CCBHCs are responsible not only for mental health and substance use outcomes, they're actually responsible for physical health outcomes. So things like helping people manage their diabetes, their blood pressure, getting all their preventative visits. So they're doing a lot to try to wrap people around in a space and setting that makes the most sense to them. So we're very excited about all of these whole person projects. Really want to thank Dr. Carrie Brown, Dr. Gary Maslow, Catherine Shelley, Alex Schur from our team for coming today, talking about these things in a really quick amount of time. But if you're interested in any of these, hopefully you know how to reach us. On the last slide is probably our typical QR codes. If we go to the last slide for how to sign up for Hot Topics, where to find today's recording. And if you have any questions about today, about how to get more information, how to get involved in any of these things, because we want you to. So thanks everyone for joining us today. And I'm going to hand things back over to Dina to take us out.
Thank you, Kelly. The recording and presentation slides for today's event will be posted on our Community Engagement and Training webpage. The link is included in the chat. There will be a brief survey following today's webinar, and we would appreciate your time completing it. Our next side-by-side webinar will be held Monday, August 4th from 2 to 3 p.m. Our topic will be reducing stigma and increasing treatment. We hope you will join us then. This concludes our webinar for today. Thank you for attending.